I will click the broadcast thing to tell us to go live, and then Mark, you can introduce everybody and get started.
All right.
All right, Mark, you're good to go.
Okay. Good morning, everybody. Hopefully you can hear me. We appreciate you attending this really important webinar this morning. We've unfortunately, as you know, had to cancel all of our spring seminars. So I think this will be really important and helpful and timely to hear about the latest from the modeling that our researchers are doing and who they're collaborating with today. I would also first like to actually say that I hope you're all safe and well as your families. So I'll introduce our speakers, and then they will take turns presenting what they're doing for about 30 minutes. So the plan is to have a good 30 minutes for questions and answers. So we're going to hold those questions until after they're done, about 1/2 hour. And then the speakers will instruct you on how to use Zoom to raise your hand, and then we can let you ask your questions and have a discussion. So I'll first introduce Dr. Kelly Searle. She's an assistant professor in our Division of Epidemiology Community Health, and she received her PhD in epidemiology from Johns Hopkins Bloomberg School of Public Health. Dr. Searle's research has a main focus on malaria transmission dynamics across different endemic settings and the implications for developing and implementing control and elimination strategies. Her work integrates traditional epidemiologic methods with molecular biology, GIS and spatial sciences, and ecology across field sites in Central and Southern Africa. So it's sort of interesting to hear a little bit about the research that our investigators are doing, both locally and globally, and they're able to pivot and step outside their usual roles to work on this pressing pandemic that we'll be hearing about today. And then Dr. Kumi Smith is also an assistant professor in our Division of Epidemiology and Community Health with a PhD in epidemiology from UNC Chapel Hill. She usually studies HIV and sexually transmitted infection epidemiology, particularly in resource-limited settings. She's also interested in infectious disease dynamics, social determinants of health, and health equity. And she's the director of our HIV/STI Intervention and Prevention Studies HIPS program here at the U. So without further ado, I'll welcome our speakers. Thank you all again for attending, and we'll get started.
Awesome. Thanks, Mark, for the introduction. And so Kumi and I we've split this up, and we're gonna do kind of a brief overview of the current Minnesota COVID-19 model, kind of focused on our roles, what's been done so far, and go into some of the politics of modeling and other publicized COVID-19 models. And as Mark said, we're only going to talk for about 30 minutes, and we hope to have a good discussion afterwards with questions. Slow down, Kumi. Okay, so this is me and Kumi, and so I'm going to start off with part 1, and then Kumi's going to take over for part 2. Next slide. All right. Next slide. So before I get started and really roll into the modeling, I wanted to make it clear that Kumi and I represent a much larger team of people that contribute to these efforts. So this is our modeling team from UMN, across the School of Public Health and the U. And we also work with a much larger team over at MDH as well. So I just want to shout out that we're part of a much larger effort in this. Next slide. Next slide, Kumi. Oh, cool. So we won't be going into a lot of the details of the model other than the results that have been presented by the governor so far, but we can go into the process, the lessons learned, and the challenges through this all. So every model has a trade-off in complexity versus feasibility. This is especially highlighted under a significant time crunch like this. So even with limited information on a virus like coronavirus, you can develop an incredibly complex model that could potentially take forever to build, parameterize, run, and get manageable outputs. So in this case, for us, it was important to start with what we knew, what was feasible to do in the time frame we had, and go from there. Our goal was to have a model that represented reality, was based on empirical data, and built specifically for the population of Minnesota. So we wanted to make it as complex and informed as possible, that was also feasible to run in a limited time frame, validate, and have results that could be interpreted to the public. So our first version of the model was presented when the governor announced the stay-at-home orders. This was the first version of the model with output under different scenarios. The first scenario being do nothing, so essentially the scariest. Everything was based on data that was available at the time. We kept updating afterwards to refine the model as new data became available. And so when a model is valid and is working correctly, you expect output to change as the parameters and inputs are updated. So academically and scientifically, this is expected to have revisions as we go. But revisions in progress can lead to unease, especially when everything already seems so unpredictable. So when the model was updated, and as it continues to be updated, the results and revisions can seem to hurt the credibility, particularly when these are presented to the general public. This isn't something uncommon at this point, since nearly every model presented has been revised and updated, but this can lead to some perceptions of distrust amongst the scientific modeling process. But it is a normal process and expected as these models are being developed at the same time as we're progressing through this pandemic. It's also important to note that these models are not the only thing driving the decisions of the governor. These models are just one of many, many factors. Personally, professionally, I appreciate that the governor is listening and considering the science and the data surrounding the epidemiology and is open to the model results and interpretations. But we all know that there are so many other economic, social, and health factors outside of COVID-19 in the mix right now. So the models are one factor, but they do seem to have a pretty high weight, but they're not the only factor. But as one factor with high weight, they're getting a huge amount of press, which is cool because people are talking about epidemiology and these transmission models, but there seems to be kind of this enlarged feedback loop in the release of the models and real-time critique of every model that comes out. This is really important for transparency, but we're still in the process of realizing what real-time peer and non-peer review of models looks like at this point. This real-time review through the feedback really brings to light the challenges in creating these models beyond just a model's structure and function. Next slide, Kumi. Cool, so these are the initial model results that the governor presented under no mitigation, and then the current scenario that we're in with the significant smart mitigation and the stay-at-home orders pushing kind of the curve outwards. And then next slide. Cool. And so this is what the results that the governor presented most recently this week. And these will be updated later this afternoon. But they're much more succinct. And of note, now we have confidence intervals on things. Next slide. Cool. So speaking of the challenges, which have been numerous, but we'll touch on just a few here. One of the big factors we've had to address is the limited amount of data coming from the US right now. A large number of our parameter values continue to be informed by studies from China. So given the suboptimal testing in many settings, reports from China provide the most complete and detailed data available, as active monitoring systems were implemented throughout China relatively early in their outbreak. We haven't had that level of response and ability to collect data in the US. However, wherever possible, our model parameters are informed directly by data from Minnesota, in particular, demographic information, the distribution of comorbidities across the age groups, as well as data on the number of cases and deaths in Minnesota. The published estimates so far of R0, or the basic reproductive number, are still highly variable. As much as we think we know, we're still learning as we go. And it's important to note that R0 isn't a fixed number. It's dynamic value that can vary geographically and over time. And we anticipate that this number will continually be updated and revised as more data comes out specifically from the US. So far, the COVID-19 death counts have been problematic. Deaths occurring outside of hospitals and ICU care settings are still poorly understood and poorly documented. This obviously leads to undercounting of deaths, but deaths are kind of one thing that we can count. They may not be the most realistically viable option for monitoring at this point, but they are being documented in some way. So as more information is collected on this, we hope to update that. And there are some caveats that come with this, which we can discuss kind of at the end. The next 2 points are those that I think have kind of the greatest uncertainty still remaining and have been really difficult to ascertain. So there's this unknown role of asymptomatic infection in the spread of COVID-19. There's still a ton of uncertainty around the proportion of infections that remain undetected or asymptomatic or minimally symptomatic that we're not capturing. We know that the testing availability is suboptimal in the US. More challenging for model-based predictions is the heterogeneity in testing policies across states over time. So we can't actually gather good information on this factor. In addition, new information is continually emerging regarding infections acquired from presumably asymptomatic cases. So this is still a huge unknown, specifically in terms of the proportion of cases that are asymptomatic, unidentified, and the transmissions that are occurring from these infections. Additionally, the extent to which measures actually reduce contacts is unknown, and it's highly variable. Contact patterns are difficult to quantify under normal conditions. The proportional reductions under different mitigation strategies that we're in right now is completely unknown and highly variable, and still remains difficult to quantify. The graphs on the bottom show what Google has been collecting and publishing, and these are specific to Minnesota, but these don't really capture the entire story. Next slide. Cool. So in terms of kind of public blowback with all these challenges and everything, this just shows some screenshots of internet comments from this strib a few days ago on the updated stay-at-home orders. And in this, it's important to note that we had our first case of COVID-19 in Minnesota on March 6th. So we're really just over a month into this, even though it seems like it's been a really, really long time. And we're only 2 weeks out from the initial stay-at-home order and the introductions of version 1 of the model. So there's some frustration right now, and that's completely reasonable from a public perspective. We get that even when we go through the preliminary model results ourselves. But we keep on working and moving forward to help inform the policies based on the data we have. So with that, I'm going to turn it over to Kumi to expand upon the politics of modeling COVID-19.
Thanks, Kelly. And you haven't quite pointed it out, but these are some really our favorite comments that we got from when the governor released the more recent updates of the model and the extension of the stay-at-home order. Our favorite one is Goofy Grape, who says, "All bow down to the model, do not question the model." So I feel like we kind of love that. So I'll be talking more about sort of the ecology in which our model exists and how modeling has become a sort of a much more popular public topic. So in Twitter, in academic circles, and in mass media, suddenly everyone cares a lot about mathematical models. And this is not surprising because this is the first time for most of us that models have had a really direct and immediate impact on our everyday lives. But so cutting through all this noise and getting to the part that matters is hard. And we're having a lot of trouble doing it ourselves. It's a lot for us to try to be doing the modeling and to also keep up with what other models are doing at the same time. So what follows here is our best attempt to share with you what we've learned and what we know. There's a fair amount that might be missing. So those of you who are probably pretty steeped in the literature, we would love if you chime in and share with us any updates that you know of, other resources, things like that. But of resources that are out there, one that I really like is 538's article written for lay audiences titled "Why It's So Freaking Hard to Make a Good COVID-19 Model." And this is because Nate Silver of 538 thought he might try to model it, concluded it was too hard, and actually backed out of it. It's one of the rare cases that someone who probably should not be modeling this decided to abstain from it. So I find this to be very impressive. To this article title, though, we would argue it's especially hard to model COVID-19 in the US right now. A quick aside, we'll call these COVID-19 models, but just for the sake of being picky, since we're all scientists, these are actually SARS-CoV-2 models, so we're modeling what the virus does. COVID-19 is the disease. It's okay when talking to friends about it, but just to be sure we're clear that we're not just modeling disease. And so when we're talking about how to model this epidemic in the US, we are now dealing with trying to model in the middle of a broken public health response. So all modelers talk about how we are flying blind, you know, in a good situation, but now it's like we're flying blind in like a hurricane. Kelly alluded to the lack of systematic testing, and that means we have no idea of our denominator, and it's our denominator for everything that matters. So it's when we say we need to know things like the proportion of cases who die, the proportion of cases who are hospitalized, or the proportion of cases that are symptomatic, we just don't know what we mean by cases. Some people would argue you should say infections. So the best models can do is to try to parameterize the extent to which we're underestimating this and then fit it to the data. You can see how that can lead to a lot of variety and a lot of challenges. So outside of China, the epidemic is reaching these proportions that we had not seen before. So the Chinese epidemic and the epidemic outside of China are now two different beasts. And ironically, we need to know more about what's happening outside of China because it's more relevant to us. However, because it's creating so much chaos on the ground, data collection efforts are much weaker, and so we're getting a lot less good quality information out of these settings. So what we have left to use is Chinese data, but that's from a completely different sort of situation. And it's all we've got, though, because in our situation, the measurement is just not there. I've added a second title here at the bottom. This is another good sort of digest out of Wired. I can make sure that our organizers share or make these slides available to folks later so that you can check out these links yourself. So I talked about the world of modeling. I wanted to just share a little bit about sort of key models that have picked up a lot of press attention or that sort of show us, you know, how challenging models are when they're subjected to immediate and very aggressive scrutiny. Rightly so, but it definitely it raises the stakes for the modelers, many of us who are not necessarily public policy experts. So there's a situation in the UK when we have seen the same version of the model backtrack. So it sort of reverses what it originally said. That's the imperial model. There's another model, the Oxford model, which tried to explore different hypotheses. Both cases led to very strong reactions in the media and in the public. So just wanted to share with you a little bit more about what was going on with these models in the anticipation that you might get asked about these things yourself. So to the best of my understanding, the imperial model was essentially a request made to modelers at Imperial College of London to inform Parliament's decision about what to do. So there's actually not just one imperial model output, there's 3 versions at this point. The first version was just exploring what social distancing measures would do. It was only presented to Parliament, and the conclusions that it drew were that social distancing would help, but that less severe controls would still reduce the epidemic's peak and make the rebound less severe. likely due to herd immunity. Then they revised this model and released what is now known as the March 16th version, which was vastly revised and widely credited with getting the UK government to essentially shut the country down. And that's because the UK deaths were now estimated to be about 500,000. That same model did include the US, and the US was placed at 2.2 million. So some people believe that this is also what motivated the Trump White House to react more strongly. Then later on, the third version of this model was again an update made to Parliament in which the 600,000 deaths in the UK was reduced to 20,000. This is probably due to the fact that it was now accounting for the new social distancing measures that had been put in place. And because the R0 that they were estimating and fitting to was updated and increased in light of new data that was coming out of Europe. This is exactly what models should be doing, is updating and revising their revisions in response to new data and in response to the new reality on the ground. However, the White House crapped all over this model and said, how can we trust a model that goes from 500,000 to 20,000? In the case of the Oxford model, what this model was doing was completely different. It was sort of a theoretical model to explore different hypotheses and say, are there any other plausible explanations for why we are where we are today? So it was just taking different scenarios and seeing, could these wildly different scenarios possibly provide alternative explanations? One of the things they tested was the assumption that SARS-CoV-2 had been circulating early in the UK since January, immunizing most of the population by the time the model was actually being published, and therefore slowing the spread. So this was completely hypothetical, but the press picked this up as half of the UK already has coronavirus. There's an entire literature online now explaining why that is a misinterpretation of it. So the initial response followed by then the counter response is this incredible, it creates this cacophony of noise on the internet. So I'm sure many of you have spent time in that rabbit hole. I just warn you, maybe put a timer on so that you emerge from it within a reasonable amount of time. There's a third situation, which is when models diverge. So these are when different models trying to describe the same epidemic tell two different stories. So the first that's kind of, I think, considered to be a little bit more of a widely publicized model is that was issued out of Harvard. It is published. Oh, I'm missing a reference for the second model. Sorry about that. I'll add that before sharing. So this model is published, but the initial release of these results were issued to the White House in sort of an official report. And we now understand that this model was turned around in about 2 days. The White House tapped modelers at Harvard, fed them a bunch of scenarios that they wanted them to try, and were told, have it to us by this time and date. A 2-day turnaround time is insane. And, Mark Lipsitch, who oversaw the process, did tweet about it later, trying to explain that, we did our best and this is part of our service, but obviously all types of efforts have to be taken with a grain of salt. So the Harvard model roughly said that one-time interventions would result in about 500,000 cases, but that because of the nature of the fact that they are one-time interventions, that an eventual resurgence would happen later on in the year. This is pretty widely reflected in other models as well. The idea that if right now, in the absence of effective treatment or vaccine, if we can implement social distancing, we can certainly flatten or even move back the curve, but we can't necessarily completely eliminate SARS-CoV-2 from circulating in our populations. So I don't think any epidemiologists were surprised by the results of the Harvard model, but Deborah Birx of the White House, the now, constant face in the White House press briefings, she's the coordinator for the coronavirus task force. She said that this model did not, quote, match the reality on the ground. And so essentially these results have been summarily thrown out by the White House. And the other model that I think has now been sort of upheld by the same people in the White House is what is now being called the IHME model, which stands for, help, Kelly, I forgot to put it in.
It's the Institute of Health Metrics and Evaluation.
Thank you. We think of it as the UW model. This comes out of the University of Washington. So this model originated actually out of a collaboration between the UW IHME Institute, which is basically a sort of infectious disease dynamics institute, which looks at these types of issues as part of their job. But they were recruited by the University of Washington Medicine hospitals, and we're told, you know, we really need help trying to figure out surge and how to prepare. So modelers from IHME were embedded into the team in these hospitals, and they were getting daily data out of the hospitals. It really helped shape Seattle's response. Because of its success, IHME started getting a lot of requests from other health systems to please, you know, share this model and help them. And this created eventually enough pressure for the IHME model to go public. And that is when, pardon my language, shit hit the fan. So the IHME model is very optimistic. Our Minnesota model that Kelly just showed you predicted 60,000 hospitalizations at peak. Our current model runs have shown obviously less than that, but at that time that our model was saying 60,000 for Minnesota, the IHME model showed 5,000 for Minnesota. Just as a note, you can sort of run simulations state by state in their online tool. So even that kind of difference, you can imagine, for us created mass hubbub, and it required us to try to reverse engineer what these folks had done. And even then it takes a lot of guesswork. So we're in the middle of trying to do these models, and we have to drop everything and figure out what is this IHME model? How is it different? And why are these stories diverging? This is not something that we normally have to do in academia, and it's been a learning process. The White House, as I said, is now holding it up, and so I think a lot of the media has picked it up too, and I anticipate that those of us all in public health are probably facing questions about what's the deal with this model. So we just want to share with you a little bit of what we've been concluding about, or what we've been learning about it. So if you do believe this model, things are looking pretty good in many states by practically mid-May, but this is predicated on some key assumptions. And that is why I think the best description of the IHME model is not that it's wrong, but that it's really portraying the best case scenario outcome. The curves generated by the IHME model have wide uncertainty intervals around it. But note that even the lower bounds of the uncertainty intervals from IHME model curves are probably the lower bounds of an optimistic curve. So it's different. It's not the worst case scenario. It is the curves of uncertainty around the best case scenario, if that makes sense. We take no pleasure in criticizing the IHME model, but we think that it's important to lay some of these things out, again, because I think you might be facing some questions soon. The key thing about the IHME model that departs from pretty much every other publicized model is that it follows what we call a single equation approach. It's pretty similar to what has widely been described as Farr's law, which is an approach developed in the early 1900s based on the observations of Dr. Farr, who observed that when epidemics happen, events rise and fall in roughly a symmetric pattern that can be approximated by a bell-shaped curve. And that this can be captured in a single time evolution formula. So since then, it's been used to forecast a bunch of stuff very successfully, I believe including SARS. But it was used at one point to predict the HIV epidemic in the States, and predicted that it would have died out by 1995. So as you can see, the track record is not perfect. Put simply, what it's doing is it extrapolates cases from death counts. And then the rest of the model lays out mechanisms, and the other models that we are all using really diverge from this approach, because what we're doing is sort of laying out the underlying mechanisms by which disease or by which infection is acquired and spread and how it causes disease. So comparing something like, say, our Minnesota model to the IHME model, we would argue is something like comparing apples and oranges. Ours is sort of, not ours, but these other sort of mechanistic models really base transmission on what the underlying mechanistic process is. They're sort of bottom-up process-based frameworks, and this is really essentially extrapolation. Our second point is that it's highly dependent on recorded deaths. Naturally, Kelly's already gone into how problematic death counts are and are probably more likely to become. It operates on a very different time scale. This is probably a relic of the fact that it was developed for hospital systems to plan on a day-to-day basis. So it maps what happens on a 4-month time scale. Most other models are much longer, at least a year. Our Minnesota model is also a year. This is key because this type of feature will tell the model how long it should think, and this may not capture it may not fully capture the long-term dynamics, specifically the second peaks that we might see further down the line. The interventions that they make assumptions about are also, they are quite different. They're very granular. They do look at when states implemented each of 3 kinds of interventions: school closure, business closures, and stay-at-home orders. But it does assume that by, I think, April 7th or so, that all states would have implemented the full measure of lockdowns, and that furthermore, they would have maintained them until June 1st. That's a pretty extreme assumption, even in the whole ecology of models out there. Finally, some folks have played around with just experimenting. If you sort of feed the model like 1 more extra day of data, what happens to the predictions or the projections that follow from, you know, the day on which you stop feeding the model data and it becomes a prediction. And they have found that the peak timing, so when that peak happens, is very, very sensitive to this type of perturbation. And that's not necessarily surprising, but it does suggest that the underlying mechanism of this, for whatever reason, is very small, very sensitive to small changes like that. And it obviously raises a few questions about its utility, especially for how it's being used now, which is to inform federal policy. I will say though, I think a strength of this model is that they have put this fully online and anyone can really play with it. Our group is trying to get there, but we're not, because it takes a lot to really vet all of our code, all of our parameters. And I think the fact that they were able to put this up and probably knowing full well the flack that they would receive is admirable. A final word is the fact that a lot of commentary has followed about these models, that why is it that the outcomes predicted by models are so extreme? It seems like we either all die or we all live, and why is there no middle ground? In response to this, the biologist Carl Bergstrom at UW had a great response that he put on Twitter, and he accompanied it with this hand-drawn diagram. So he said to suggest that we think of epidemics as if it's a rolling ball. He says, imagine rolling a ball along a ridgeline. It might track right down the center of the ridge the whole way, but far more likely it will end up on one side of the ridge or the other. Epidemics work a bit like that. Either you manage to suppress the epidemic and end up on one side of the ridge, or you lose control of it and end up on the other. There's some middle ground, but not much. And for those who care, he backed up this analogy with a little bit of quick modeling that showed that the relationship between the R0 values that we assume we have and the proportion of the population that ultimately ends up infected follows this curve, which is sort of sigmoidal, and it means that the range of R0s in which we sort of end up in that middle ground is actually really small. So this relationship between the R0 and the proportion of us that get infected is probably pretty realistic and dictates why it is that epidemics often do play out this way, which is that they either seem to veer towards the best case or the worst case scenario. So I think therefore it's fitting to close with Mark Lipsich's quote that the more it does the job, as in the more our interventions do the job of controlling the epidemic, the more it will have looked like it was all an overreaction. So with that, we will gladly take it over to questions. Oh, and right, we wanted to share with you all how we were thinking it would be best to take questions, which is to use the raised hand function. For those of you unfamiliar with it, if you click on your Zoom screen, a menu should appear at the bottom. If you click on the part that says participants, you should see a list of everyone on this webinar with your name ideally at the top. In the bottom of your participant side panel, there's a little button that says raise hand. If you want to go ahead and raise your hand, we hope that it could be more of a shared discussion. And so that, folks can also maybe raise hands and talk to each other. So we'll go ahead and take questions in order of raised hands if that works for everybody. And Jeff, were you gonna unmute people as we go?
Cool.
Okay. So I think Dr. Linda Frizzle, if you'd like to.
Commonly pronounced Frizzell, but we'll let it go this time. I'm actually in the Dean's office at the School of Public Health. And first off, I have to compliment that my students are doing exceptional on Zoom classes. But they are, of course, all graduate students, but they are challenged for their final exams to do something that can contribute to help solve some of these present and future pandemics. So with that said, one thing that I offer people, wherever they are, I'm soon to be 70 years old next month, but from that, first of all, I'm a rural person. And so isolationism doesn't bother me because it was never an important part of my family or my culture. And so I offer to help people if they just want to shoot me an email, which they can find at the university. I'd be more than happy to chat and help people maybe get some relief from that. And secondly, being a baby boomer, I was raised by Depression era parents. And so it's entrenched in me and my culture to plan ahead and always have extra things. My kids always made fun of me until about a month ago. And now they're like, wow, Mom, you got like a regular grocery store. And I go, yep, did you learn anything? But the main thing that I wanted to stress, and I so appreciate what you guys are doing, it is unbelievable. I can't imagine, you must have been up night and day even getting ready for this presentation. My concern is I see this aloofness in the news every day. I challenge my students to tell me stories, and they do. And it's like, I don't get it. And I don't know how many of you have ever been teachers before, but ever had the opportunity to teach junior high kids. My whole objective whenever I did that was to keep the kids alive. And it's appearing that our whole country has got this mentality that they're invincible, it doesn't apply to them, so they go out without masks. We as public health people need to help people to understand that a virus is so small that it can only be seen by an electron microscope. And so the viability, and, you know, there's lots of theories going out now. What's concerning me is with mosquito season coming up, I am watching that closely. But regardless, people don't understand. And so they subject themselves and others to the possibility of contamination. Whenever I see food workers doing takeout, they hand it to the person barehanded. The person takes the package barehanded. It shows them preparing food, no masks on. And we know now that logically, all of us in public health knew that whenever you breathe out, those droplets are pretty small. And certainly if you sneeze, it's like huge. And if you're out running around Lake
May I just wanted to point out, we do have a number of folks with questions. I just wanted to ask did you have a question for us too? Your comments are really valuable, but we just want to make sure we leave some time.
Yeah, the main thing I want to do is just share that if anybody needs help, I'm here.
That's wonderful, thank you.
Thank you.
I think the order, I can't tell, but maybe is it Ryan next? Ryan Demmer?
I think Diane's next.
Oh, sorry, well.
Yeah.
I think
Ryan, you're unmuted, so you can go first if you want. I'm sure Diane will happily yield.
Oh, yeah, Ryan, go for it.
okay. Can you hear me, Kumi and Kelly?
Yeah.
All right. Sorry to jump ahead, Diane. I'm not sure how that happened, but thank you very much, Kelly and Kumi, for doing this amidst everything else. It's fantastic. So my basic question is, I'm wondering if there's a centralized place for modelers to state the questions that they need answers to. There's so many people trying to help that could provide useful answers, but they often don't know what questions need to be answered, or that they might even have the ability to answer them with tools they have. So is there any central repository for collecting those questions or posting them?
I can answer that. I don't know, but I do know that the folks at Hopkins have put together a massive report about modeling COVID and pointing out all of the shortcomings, which one of them is how siloed this whole process has been. And I know that one of the proposals is to create some kind of center that would work roughly like how the National Weather Service works, where there's a much more centralized sort of repository that scientists can share data, share questions, things like that. I can include a link for that, but I don't know, maybe Kelly or Ryan, have you all heard of anything?
No, I haven't seen any sort of centralized repository for like the questions and how different models are approaching things. We are seeing more repositories kind of on papers that have been published so far, but and the parameters that can be included in models coming from those papers. But yeah, a lot of the work seems to have been going on siloed, and hopefully moving forward, we can kind of come together a little bit more.
Thanks.
Thank you so much. Can you hear me?
Yep.
Thanks so much. This is amazing. You pulled this together so quickly, and it's so informative and so well explained. So thanks to both of you. I wanted to ask two questions. One was, do these models, are you able to take into account other costs? So, by all of the economic things that we're seeing, we know there will be other problems. Are there models that take that into account, or deaths from other causes that may not be happening because people, particularly older people, are dying from COVID-19? And then my other question is, are you able to look at the planned reduction through specific strategies such as school closures?
How do you want me to do it? You want to go? I'll follow up.
Okay, so for the first part, for the specific model that we've built for Minnesota and what most of the other models do, they really only are modeling COVID transmission and the disease outcome. So they're not really built to take in a lot of the other complexities that are happening, and specifically the economic costs and everything else going on, but really just can look at transmission. And but down the line, I would foresee some more complex models developed later that look at kind of the whole picture. Right now, really just the efforts are going into trying to understand specifically what's happening right now. Kumi, do you want to comment on the first part?
The economics? No, I think it's funny though that Shalini in her normal job is a cost effectiveness modeler, so she would be a good person for that, but that's not what's being asked of us.
Yeah. And then for the second question in terms of the specific interventions and how the models take those in. So we make assumptions about which interventions reduce contact patterns and how the reduction in contacts between people, that proportional reduction impacts the R0 and transmissibility. So that's how the model takes that in. And so we make assumptions about how school closures affect or reduce contact patterns between different age groups, as well as when working from home reduction in contact patterns, and then the larger stay-at-home contact reduction in contact patterns. So that's how we kind of account for those. Kumi, do you want to add on to that?
My understanding was that we're still making pretty blunt assumptions, that we just take sort of age-specific mixing that happens in the population, and we're just scaling it down by a certain percent.
Yep.
In future runs, we hope to be able to make it more specific, because obviously schools shut down mixing among kids under 20, whereas businesses shut down mixing among, a broader range of people. But in our time limit, we've actually made that a pretty simple assumption, and it turns out that's not unusual to be doing right now. Yeah. That's a great question.
Thank you very much.
Thanks.
I think next is at Deanne Lazovich. Oh, there we go.
Mute. Okay.
Hey.
Hi. Well, again, I just want to add my thanks to this presentation, to all the work that you're doing. Really is, I just can't express how grateful I am for the work that you're doing, and how the university is contributing in this time, and public health, at the university and in the state. I'm just so impressed. I just want, now this might just be a really uninformed question, but ever since those first two side-by-side slides that the governor showed of, you know, why we were going into stay at home, the only thing that changed under mitigation was shifting the curve to the right. And I would have thought that with social distancing, we would also expect that curve to decrease in terms of total number of cases. And I've just, maybe I have not been able to look at that figure correctly.
No, that's a very, very smart question. And we spent a lot of time yesterday talking about how to explain it, even to ourselves.
Okay, that's good to know, because this has confused me from the very beginning. And how does that look like we're, you know, how do we communicate to the public that there's, you know, a benefit with reduced cases that then leads to subsequent declines in hospitalizations necessary by showing curves that look all identical except for a shift? I don't know.
Yeah, I mean, I think to the best of our understanding, well, first of all, I think a whole hashtag flatten the curve campaign has not really helped the cause of modelers, because it turns out flattening the curve is really, really hard to do. And in the US, where I think the worship of the market and the market economy and equating that with, you know, the value of the market being equated with well, some people are just gonna have to die, has made those trade-offs seem equal. And therefore, there's a real reluctance in any state government to project shutdowns or social distancing beyond, say, a month. But what we know from a lot of the UK models is that for us to flatten the curve, we have to have really prolonged social distancing on the order of months. And right now, no state government is really asking for scenarios like that. They're, I think, maybe for political reasons, finding it better to ask us to model in piecemeal fashion, where they say, okay, now what happens if we extend it another 4 weeks or another 2 weeks? And that's why our model's not going to show you a flattening. It's just going to be a hashtag postpone the curve. Kelly, do you want to add anything?
But it should, if we, well, I guess you're saying that only if we do it for a long time will we see a reduction.
Exactly. It's about how long we keep these policies in place, because what we need to keep in mind is social distancing does not mean we all stop coming into contact with each other, period. If we literally, all of us could just stay in the same place and not contact anyone outside our households at all for 2 weeks, and I'm talking literally everybody, all essential workers, people who keep our power plants and electricity plants going, everybody, we could actually get rid of SARS-CoV-2, but that's never going to happen. So social distancing is a mitigation measure. It's not an elimination strategy.
Are we focusing then on the wrong message to the public? I mean, shouldn't we be knowing more about what it's really going to take? I'm so frustrated by the short-term thinking in all of this.
Yeah, I mean, I don't think that the curves of the Minnesota model are going to be making a national splash. And I do think the imperial model, which has shown different strategies, and it does show a flatter curve, are still persuasive. But I think for any of us who are consuming curves from models like the state-by-state basis type of models and wondering why it's not flattening, I think it's useful to have that context and knowledge. Yeah. We just worked on a FAQ, like a frequently asked questions document, to accompany all of our publications or all of our model code that will go out, and that is addressed in there. So we're trying to make sure that that message gets out there, but you're right, messaging is tricky.
Yep.
Thank you.
Kelly, did you want to add anything? Or?
No, I think, yeah, you covered pretty much all of it. So I think we skipped Rhonda, Jeff just said, so.
Okay.
Right. It's actually a follow-up to Deanne's question around, you know, how do you communicate really complex concepts to the public, and like modeling, and maybe you can share what you learned about, you know, how as public health researchers, we, you know, can communicate very complex issues like modeling to the public. Again, what have you learned? What do you think is important to try to convey to the public using these kinds of models?
I can start, Kumi.
Yeah.
So it's been kind of a crash course in conveying really complicated information about the modeling and transmission and epidemiology in general to the public. I've learned pretty much to just be as clear and transparent as I can possibly be, and to explain things kind of in a way that people can really understand. It's been difficult, but a lot of the public part of explaining the models is being done by the governor. So it's kind of like a chain event. So we work on the model, and then basically Shalini and Eva explain that to an intermediary and to the governor's team and the governor, and then the governor then explains that. So it has been kind of like watching in real time, sort of a game of telephone going on, where we get from the model and the outputs and what we understand it to what ends up being presented. And so far it's actually been pretty accurate, other than some interpretations of what 95% confident intervals are. But yeah, Kumi, do you want to add on to that?
Yeah, well, we would also add, for all of you folks who regularly deal with 95% confidence intervals, the intervals that you're going to see on curves coming out from the Minnesota model, that's not what they are. They're uncertainty intervals, so please don't interpret them that way. And we have an FAQ on that. I would just add, Rhonda, that I found that it's such a balance, because if you try to if you oversimplify it, you come off being patronizing and perpetuating the idea that models are black boxes. So I actually sometimes do kind of share with folks what I do think is pretty intuitive about compartmental models, which is that, you know, you just kind of put everyone into a category based on their disease status. Can you get this disease? Do you already have it? You know, are you sick from it, more or less? And then you just kind of make assumptions about how people move through those states. And then you watch that happen iteratively and, you know, make inferences based on output. For those who are interested, that seems to kind of enlighten a little bit. But it's tricky, because I think for us, the communication largely has been a one-way street. We just work really, really hard on the messaging and the reports and the, you know, the web appendix and all these kinds of things. And then all we really hear back are like these, you know, sort of nutty comments on the Strib comment section. So it's hard for us to say how it's landing, but yeah, I agree. We've learned a few of those types of things.
Thank you. Thanks.
Jeff, I'll let you pick who's next. Oh, I think it's Ariana.
Hi, yes, thank you so much for this presentation. It was really informative. This is my first introduction to ID modeling, so that's been a really interesting time to learn about it. You mentioned in an earlier slide that there's a difference between modeling the virus SARS-CoV-2 and modeling the disease COVID-19. And I'm wondering if you could clarify that, because I'm a bit unclear on that.
Yeah, it's not so much that there's models out there that do model COVID-19. I think I was just making the distinction between, as epidemiologists, we don't want to just use a blanket term that this whole epidemic is about COVID-19. This epidemic is about the virus that causes COVID-19. It's very important for models to acknowledge how much SARS-CoV is circulating in the community, because there's a ton of, as you have probably read about, there's a lot of folks that we think are probably infectious to others, but are not showing symptoms and are not going to get tested. So our model has to try to take all that into account. So we really do care about SARS-CoV-2. And then one of the outputs of the model is, well, therefore, how much disease will we see? How much COVID-19 will we see? So that was the distinction I was trying to make. But does that make sense?
It does, yeah, thank you so much.
Great. I think, is that you, Aaron?
Yeah, hi. I like the presentation. You said that no one's asking for longer term models, but is it not the case that we're prolonging things, and in fact, until there's a vaccine, we're going to probably be not returning to work? I'm trying to think about return to work. We were saying, well, we've got participants in research studies. When could we see them again? We can't put them at risk. Does risk have to be zero? Could we protect ourselves and them enough to do our face-to-face surveys? When do you think that sort of thing would happen?
I can answer just the issue about the timescale. I want to make the distinction between timescale and then the projected duration of interventions. So like I was talking about how our model projects things out for a year and the IHME model only for 4 months. That's a matter of how long the model is told to try to guess what's going on. But even though our model looks as far out as a year, the governor's office is saying, please run scenarios where we do either 2 weeks or 4 weeks or some such really short-term interventions. So, you know, if we did want to, Erin, I think we could try to model what would happen if we implemented really harsh social distancing for months and months on end. And I think it's hypothesized that eventually with stringent enough measures implemented uniformly everywhere, that maybe this could be gotten over without a vaccine, as arguably China may or may not have done. But you're right that I think a lot of this waiting game is kind of, maybe not explicitly, but is kind of inherently being made in the hopes that a vaccine appears in time. And so this preparing for the surge thing is partly about making sure we don't have unnecessary death, but it's also kind of hoping that we're buying time for the vaccinologists. I'm sorry that I don't have advice on what to tell your participants. Our models give us no insights that far out. Kelly, do you have anything?
Yeah, yeah, it's tough. And I mean, I think that we're constantly kind of being reminded that what we're doing now is a mitigation strategy. It's not an elimination strategy. So the virus is still being transmitted at low levels. Transmission hasn't been stopped. And when we think about relaxing these strategies and going back to work and things like that, there's potential that, you know, we're going to get a second peak. We don't know right now when or anything like that. So yeah, it is right now we kind of are doing short-term interventions and seeing what happens and buying time, which can be a little bit frustrating.
I believe we're at time now, so maybe we can take one more question, and Kelly and I are happy to take questions off the air, if you will. We will make sure to include our email addresses in the slides that we'll share on the same listservs.
Are you able to stay on past 10, Kelly?
I'm afraid I'm not going to be able to, but maybe Kelly can.
Yeah, I can hang out for a few minutes extra.
Okay, we've got a number of questions left that unfortunately we don't have time for, but it sounds like we can take one or two more.
Yeah, maybe from Alan, and then I'll have to hop off, and maybe Kelly can take as many as possible.
Yeah.
All right.
Great, thank you.
Okay, well, I'll be quick. I also just really wanted to indicate how incredibly important the work that you're doing is, and really just acknowledge the expertise and all the hard work that you're bringing. You know, in listening to the discussion, it seems like there's a number of outcomes from these models that are really important. And, you know, people have been talking about the number of cases and deaths, but also it seems like this modeling is really important as we think about resource allocation, particularly things like, you know, hospitals, ventilators, ICU beds. And, you know, essentially if we have, you know, a big peak where we do nothing, you're going to have a whole lot of people showing up and pretty much overwhelming hospital capacity. Whereas if we're either able to decrease the height of the curve or spread out the curve, it has real implications for the ability of our hospitals with their limited resources to be able to more effectively deliver care. Does that sound like a message that is useful for this type of communication?
Yeah, Kelly, I'll just say a few words first, and then sorry that I have to run. Alan, that's a great point, and it was first and foremost in the governor's office request for what this model does. So we have an explicit model state that quantifies the number of people who, after showing up to the hospital, will reach a critical state where they need an ICU bed and presumably a ventilator. We then count that up per run and then compare that to the number of beds that we've been told we have, which is changing, it is increasing. And so whatever is sort of the excess number of ICU cases that do not get a bed, that's sort of considered the excess death that could have been potentially avoided had they been given a bed. So that's been a major thing that the governor is really concerned about, and that has been the other aspect of policy that this model is guiding. So not just social distancing, but how many beds we need to get. Hopefully, maybe we need to work better on our communication of that. But that's a great question. Thank you. I'll be hopping off now. Thank you, everyone. Really nice to see everyone.
Kumi.
Bye.
Thank you so much.
All right, I can stick around for a few more minutes to get the last few questions, and then I'll eventually have to hop off after a few minutes, and then you can email me or Kumi directly if you have additional questions. So Angie.
Hi, Kelly, and thank you to you and Kumi and the whole team for all of the work and time and effort you've put into this. You really appreciate it. One thing that I'm always reminded about with models is the phrase that all models are wrong, but some are useful. And I wonder, and I think that's absolutely true. I think that's a really challenging thing to communicate to the public, is kind of the uncertainty in our modeling, but they can still be useful in providing guidance and in guiding policy. So one of the things I've actually been thinking about is people who are really good at doing that. And I think like meteorologists are really good at talking to the public about what they predict, but there's a level of uncertainty, and they also kind of share the inputs to their models. They share the radar and explain that well, I think, to the public. And also explain well kind of the mitigation strategies, the school closures, the road closures, things like that need to happen to keep people safe. And so I'm curious if you guys have thought at all about kind of learning from those other non-public health strategies and communication strategies for the public.
Yeah, I think that's a really awesome point. With the meteorologic models, we do use kind of standard models, and they do a great job at talking about them on literally a daily basis. But whenever their models are wrong, people get immediately really angry at the meteorologists for delivering the wrong message at that time. And I think we're kind of learning that as infectious disease modelers right now, what it means to put out these models really in real time and adjust them in real time, and really communicating that these models are one representation of reality. They're not what's going to happen, right? We give projections, but that doesn't mean that this is exactly what's going to happen. And they're based on available data. And what we're really working on, and what we've been working on a lot more, is conveying the uncertainty that goes into the estimates that we put into the model, and then the uncertainty in the output. So that really has been something that we've been emphasizing a lot more, and hoping that people that are delivering the message really understand the uncertainty around the modeling, so that can be conveyed as well. And also that this is an evolving process, and it will be updated and revised as we go and as we get more data. So yeah, it's definitely been a process in terms of that communication and understanding how the models are being perceived. So thanks. Julian's question is next. But I think I'm going to take Julian's question, and then with the remaining questions, if you could email those to Kumi and myself, because I'll need to hop off in a bit. So Julian.
Great, thanks for taking my question. Just a quick point of clarification first, and then I'll go to my question. The first point of clarification that I have is I was wondering that the peak number of hospitalizations and infections in your model, it sounds like that is occurring during a time period where you've been asked to assume by the governor's office that there would be no measures in place. So I just wanted to get sort of clarification on that point. And then my question is, to what extent are testing dynamics worked into the model?
Two great questions. So the first, we did do an estimate of the model. Our first model that we were able to get to work and to run was under no mitigation. And really that's kind of baseline to see where things would end up if nothing was done. We did that really not to scare anybody, but we did that to validate whether the model was performing correctly and what would happen when you basically introduce interventions. Did it follow kind of what we were seeing in reality? So that first model was really our baseline, and then we started to introduce mitigation strategies to see kind of where we were going, but then also to have kind of comparison. How much reduction do we see? How much were we pushing out the curve when we did introduce these mitigation strategies? So does that answer your first part?
Well, I'm just curious, the current models that include the mitigation strategies, do they assume that the mitigation strategies end at a certain point before this peak occurs?
So right now we're not, so we predict out for a year. So the mitigation strategies that we introduce are basically the mitigation strategies that we're asked to do by the governor's office. So however long they propose that they're introduced.
Okay, so if they say that we're going to be doing social distancing until May 4th, your model assumes social distancing until May 4th and then nothing after that.
The initial models assume nothing after that. There have been updates to kind of what we're putting in at this point. And that will be presented, I should plug that I think is actually being presented currently by Shalini and Eva with the governor.
Okay, great, thank you.
Awesome. Okay, we'll take one more question. So Andrea, if I'm pronouncing that correctly.
Unmute. I'm Mark's sister. I'm a biologist, but not an epidemiologist. And first, I just want to thank you for being so clear. I've learned a lot. And I'm interested in the R0 ranges. Mm-hmm. So which communities in our country have the highest and which have the lowest? And what are the key factors? Like probably population density and degree of isolating, but are there any other key factors in
right. Yes. So we're basing our estimates of R0 when we put it into our models on estimates that have come out of China and estimates that we're seeing come out of Europe and also those in the US. So it's a pretty dynamic range of estimates. Yeah. And it's hard to pinpoint in particular places what the R0 is. We use a range that's anywhere from kind of 1.5 at the low end all the way up to 6 at the high end. And that'll kind of come with all of the model documentation with references where we're pulling all those numbers from after the next press conference and when all the model stuff gets released. But the reason that there's such a wide range really is because, you know, we are still understanding the transmission dynamics of this coronavirus, and there are a lot of differing factors that go into kind of what makes up an R0. One being the rate of contact, so per person effective contacts per day, the probability of transmission if an effective contact is made, so not just the number of contacts between people, but then the probability that that contact results in an effective transmission, and then the actual duration of infection, because if somebody's infected for longer or they have a long infectious period, that can increase or decrease the R0 itself. And so you're correct in that different areas that have different rates of contact could have lower R naughts or effective reproductive rates than other areas. And this, the actual goal of kind of reducing our contacts is to reduce that part of the effective reproductive rate of transmission to get it below 1, so then we can decrease our transmission and then eventually get out of this thing. But it's difficult kind of in real time in specific communities to assess, at that point in time what the R naught is or the R effective is, just because it's really difficult to kind of measure kind of human parts of the dynamics.
Yeah, it will be interesting to see as we get data on these different polymorphic strains that are emerging around the globe, if that in itself will have an effect on R naught.
Yeah,
that's way too early to see.
Yeah.
And it will probably be so complicated too.
Yeah, I think that it's really early, it's really complex, and a lot of things right now, because we're kind of in the middle of the pandemic, the assessments that we're making and are to mitigate the pandemic in real time right now. So it will be interesting to see kind of as we go and work our way out of this, what we learn retrospectively.
Kelly, thank you so much. We can't thank you and Kumi enough for how much you're doing and for taking time out of your incredibly busy schedules to join us today. This has been recorded. For those of you who can still hear me, it'll be shared. And please stay tuned for more seminars on this topic coming up in the near future. We hope to have some announcements early next week, if not sooner. So thank you again, and everybody stay safe and be well, and enjoy the rest of your day. Thank you.
Thanks.